So, traditionally everyone's been like, oh, well, after 30, your fertility goes off a cliff. And actually, that's not the case. The research does show that after around 35, then it does start to decline, but not like, by 10% or 20% or something. It's not like, you suddenly go from your chance of conceiving is like 80 to 20. It just does kind of start to slowly, gradually decline, between 35 to 40. But what I would say is that everyone is individual. So, that's where genetics play a part. Your diet, environment, lifestyle play a part. There isn't a binary number. I wouldn't say to people that, oh, right, this is exactly when you're going to be infertile. It's just about managing expectations and saying, yes, realistically, probably after 35 does start to decline a bit, but it's not, off the cliff edge.
Fertility is often surrounded by silence, stigma, and taboo, yet it's a reality many women quietly navigate. Today's guest is Dr. Divpreet Sacha. She's a GP with nearly a decade of experience and special interest in women's health, infertility, and lifestyle medicine. Her own journey through PCOS, silent endometriosis, and unexplained infertility, despite having no obvious symptoms, has deeply shaped her mission. She's the founder of Her Holistic Health, a platform offering clear, evidence-based support through fertility, pregnancy, and postnatal care. In this episode, we unpack her story, the basics of infertility, common myths, and the real options women have. But before we dive in, I've got a quick 1-minute favor to ask, and that's to hit subscribe and join the 51% community on our website. It's completely free and it helps us grow, bring in more incredible women, and host events that truly speak to the health and wealth challenges we face. And just a quick but important note, everything shared in this podcast is for informational purposes only. It's not a substitute for personalized medical or financial advice, so always check in with a qualified expert if you need support that's tailored to you. Divpreet, welcome to the podcast. It's great to have you on. Thank you so much for joining me today. I'm really kind of intrigued to talk about this because we're going to be talking about fertility quite a bit, which is kind of something that women and people in general don't talk about. They avoid it, can be taboo in certain cultures. So please, could you introduce yourself and talk a little bit about who you are and your journey? That would be great. Thank you so much.
Yeah, so thank you so much for having me on the podcast. I'm Dr. Divpreet Sacha. I have just qualified as GP, and fertility is something that's really personal to me because it's something that I went through myself. I also went through IVF. I was diagnosed with PCOS, silent endometriosis, and I had pregnancy challenges, postnatal challenges, so effectively the whole works. And you're absolutely right. There's not enough information about infertility, IVF, the cultural expectations, and societal pressures as well. It can be really difficult, and I am going to be starting work for a company called Necker Health. They focus on lifestyle and preventative medicine, so I'll be doing that 2 days a week. But the other aspect of my job is my own platform, so Her Holistic Health, and a lot of that is around empowering and educating women that are going through these struggles. And as part of that, I'll be, I'm developing courses, and it looks beyond just the standard NICE guidance. It kind of gives you more insight into your own bodies, not just for fertility, but for hormone health, for, pregnancy, for postnatal. There's just so much limited, information that's out there, and there's a lot of misinformation out there in social media, and people want to speak to their doctors about these issues, but as a GP, I know 10 minutes isn't enough. And we also have a lot of pitfalls, cost effective, like there's not much funding for a lot of these things. There's postcode lotteries. There's a lot of issues around this care. So that's why I'm so passionate about developing these services.
Yeah, no, that's brilliant. I think, when you mentioned the word postcode lottery, it kind of made me think, because some people think that that there's no such thing as a postcode lottery, that everyone has access to everything. And I've slowly realized that actually we don't, and there is a postcode lottery. Now, the details of that we'll go into a bit later on. But can you talk me through a bit about your personal journey with fertility? I know you have a very long personal journey with that.
It probably started when my period started. So back when I was 13, I had very heavy periods, acne, all the typical works. It was put down to, the hair growth, that's ethnicity. And the only thing that fixed it was the pill. And that sorted all my problems out. I stayed on it until me and my husband started trying for family. I did fall pregnant very quickly, but miscarried. And after a few months, my gut feeling, my clinical intuition told me something wasn't right. Now, I had this knowledge and I was able to signpost myself and direct myself to private blood testing. I knew exactly what testing I wanted. I was able to organize that myself. So that put me ahead of the game. Yeah. That did diagnose PCOS. And then on the ultrasound, they were like, oh, something's not quite right. You might have a heart-shaped uterus, but we'll schedule in for laparoscopy. It was actually then they discovered that you got silent endometriosis, and I'd never had any symptoms of endometriosis, and it was stage 3, which so quite severe. I had polyps, I had scarring in my uterus, I had cysts, so I had like a lot of things, and they basically said, well, IVF is your only option. And so we were very lucky that we got funding very quickly. And again, that's kind of part of the lottery, which we'll talk about later. And we managed to get in for our IVF cycle within about a couple of months. Unfortunately, that cycle fails. And then it was looking at private clinics and trying to look at the minefield of understanding the data and the statistics, because actually what they advertise on the website is very misleading to what is actually the truth. And again, my medical background helped me interpret all the statistics, because we have to learn how to critically appraise research, and a lot of people don't have that. So we did get embryos from our first round. We were able to transfer that to private clinic. Thankfully, second time round, I had a frozen transfer, and it was successful. And so then subsequently, even though it was a high-risk pregnancy, I had a cesarean section, and I kind of had a lot more understanding about my own health, not just from a medical perspective, but from a holistic perspective, from a lifestyle, from a diet, supplement, but within a practical remit, because, I can't eat wheatgrass every day. I had to, it's a bit draining. So actually, after my daughter was born, I knew what I had to take in terms of my supplements and my diet and my exercise, and my periods became pretty regular, and I conceived my son on the second time of trying, naturally. So that's my story. Now I have a 2.5 and a 16-month-old, and compared to a lot of journeys, it was very, very short, but it was still exhausting, absolutely draining, and I felt like the lowest I'd ever had done in my entire life. So for people that have been going through this for years, I can't imagine how hard it must be for them.
So there's quite a lot to unpack there, I feel like, and I want to kind of strip it right back for now. The word infertility is often associated to women. So firstly, I want to kind of ask the basics of what does infertility mean? What is that? And how that relates to men as well, because it's not always that it's the woman that's infertile, and I feel like that word infertility, you always point to the woman, not everyone, but typically the finger gets pointed to the woman. So can you kind of unpack that a bit and kind of talk to the basic of what infertility is?
Yeah, absolutely. You're so right. So technically, the definition of infertility is the inability to conceive within 12 months of actively trying. So that's what the WHO diagnoses infertility as. Now, as for the causes of infertility, the statistics do vary according to the research, but on the whole, What they are finding is around 30 to 40% sometimes is, related to the woman. 40 to sometimes almost 50% is related to the man, and in around 20%, sometimes like 25%, there is unexplained. I hate the term unexplained. It's that the standard tests haven't picked up on an obvious issue, so it needs a little bit further, investigation. But the main takeaway from that is that actually a lot of the causes, there is the male counterpart that's causing that is contributing to the issue, or is the primary issue. And there isn't, I think, because women have to often they undergo a lot more testing. They undergo ultrasounds, they undergo a variety of blood tests. Whereas for the man, it's one test, and then if that doesn't pick up anything, then it's done. And actually in the NHS, the semen analysis is very, very basic and often doesn't check for the more nuanced issues. So there's a lot of things that are overlooked.
Yeah. See, that's the thing. It sounds like with women, there's lots and lots of tests, like you said, to kind of diagnose the issue, whether that's endometriosis or something else, right? But for men, it's not as simple as, lack of sperm, or that there could be other things going on. Now, the other thing I want to talk about is, you mentioned the pill. Now, with men, as an example, it doesn't sound like there's something that could be masking what's going on. It's almost like, they don't take the pill, they don't, so it's almost like, how do men know that they could be infertile? That's one thing, right? And with women, they take the pill, which often masks a lot of symptoms, I'm assuming, and then they go through life, and then all of a sudden, like yourself, when you wanted to try for a family, and it was proving difficult, you came off the pill, and it was only then at that point you realized that there were issues. Now, I don't want to kind of make it a negative thing about taking the pill, but this is almost like the second time I've heard that the pill masked a lot issues until they stopped and came off the pill. Now, can you kind of unravel that a bit? And I just keep hearing this a lot more, and women do tend to take the pill a lot, obviously, because they need to, for a variety of reasons.
Well, the simple thing for the first question, how do men know? Well, they don't. They literally, there isn't. So sometimes if there is issues with testosterone, then that can lead to symptoms. So, low energy, low libido, like issues with, like performance and all of that, like that can be symptoms. But on the whole, low testosterone is quite a rare condition. With the, if it's low sperm count or motility or fragmentation, there are no symptoms. So, sometimes again, like you can have like sexual transmitted infections, and that can kind of like cause like discharge, and again, but they're fairly rare. We do know that the research is highlighting that over the past few decades, that male sperm parameters, they are worsening. There has been some research linked to microplastics, but we do know that there is for some reason that the sperm count, the parameters are, there is something going on with male fertility.
Yeah.
But as to how to pick it up, it is just through semen analysis. With the whole pill issue, it's such a complex, it's very complex. So I'm all about people understanding why they have the symptoms rather than masking symptoms. So for me, for instance, now, whilst I was trying to grow my family, I was obviously not on the pill because you can't be whilst you're trying. But I did take supplements after my son, but actually I was like, my periods are still awful. I was getting like PMDD and my acne was turning, hair growth. So I was like, I know what the issue is. I understand why I have those symptoms. So I'm actively choosing to go back on the pill because I know it suits me. But that's very different to someone that's having symptoms or having issues and then just being given a hormone and not really being told the full implications of what those symptoms could be. So I think that, you know, again, I think for something like the pill, the hormones, you should always, if people are wanting something to help with their symptoms and they're saying, look, I'm really struggling, then give them the options, but also make them aware that, say, like, if you do have like heavy periods as a teenager, that the diagnosis of PCOS is very difficult to make as a teenager on the whole. Because, for instance, if you do an ultrasound, a lot of like teenagers' ultrasounds will mimic those of PCOS because you're going through all the kind of hormone surges. So that's why it's not really diagnostic or reflective. But if someone is having really heavy periods, really excessive hair growth, then the kind of understanding now is that saying to them, look, we can try the pill, but what I would advise is that, look, it could be something like PCOS. So rather than staying on it for years and then coming off of it and then thinking, oh, actually, I've got all these issues that, you know, whenever people start to have a family, having that awareness then just gives you a little bit more of that breathing space and you don't feel like it's going to hit you like a shock.
Yeah.
So it doesn't cause infertility. That's the thing. The pill doesn't cause infertility, but it also, because people then get lulled into a false sense of security, because obviously the pill artificially regulates, you know, your periods. It changes your hormone. So people get lulled into a false sense of security. So that doesn't, maybe when people then go to start trying for family, they didn't realize actually there was all these issues underlying. And it can be quite devastating for some people.
Are there any other ways that you can help with that? You know, like you said, through diet, supplementation, because I know you mentioned that with your second child, you managed to conceive naturally. And was that related to you changing your diet and supplementation and things like that?
Yeah, so definitely for me, like I think that the supplements were the biggest things that helped. So for instance, in PCOS, there's a supplement called minoxidil. That's like a B complex vitamin. And a lot of the studies have actually proven to show that minoxidil is just as effective as a medication called metformin. A lot of women with PCOS, doesn't matter what the weight is, but a lot of them will have a degree of insulin resistance, and that kind of causes raised testosterone, which is what the acne and the hair growth is related to, especially those from like South Asian heritage as well. So you don't actually even have to be you don't have to be overweight in order to have the insulin resistance. And I think people always associate insulin resistance with diabetes, with, you know, being overweight, and that's not the case in PCOS. So I had the minoxidil, and I was on other things like high dose vitamin D, which again is meant to be incredibly beneficial for hormone regulation, and so like omega-3s again, and like ubiquinol. So I was on like a whole host of supplements to help with my egg quality, to help with my PCOS symptoms, and to reduce inflammation from the endometriosis. And again, from the exercise point of view, you know, everyone tells you, oh, try and exercise as much as possible. Especially for PCOS, oh, you need to, you know, do loads of exercise, but actually do too much exercise, that can raise your cortisol, which can then impact your your insulin, which impacts your testosterone. So it's about being mindful. So that's definitely what I was the second time round.
Yeah. I guess it's about balance, right? It's, you know, going completely the opposite way and exercising, you know, crazy amounts, or even taking supplements that one, you don't know whether they're going to work. I mean, I'm assuming with the supplements you took, you did your research and you knew. But for people out there that aren't in the medical profession, a lot of people will take stuff. If I turn around and say, hey, I took this and it helped me with my fertility, or it helped me with whatever, my skin is amazing, look at this, people will tend to gravitate towards that and be like, oh, well, that if that worked for them, it's going to work for me. But it's probably not going to be the case.
No, and it is really hard, because I feel like people that are, especially, if you're going through fertility issues and like not even just in general, like hormonal health issues, you go to your GP and a lot of them can, be dismissive, or they can offer you one option and it's not necessarily an option that you want to take. And then you just then feel like, oh, well, I'll kind of look on social media, I'll look on TikTok, okay, this supplement is being told, this is meant to be really helpful, but actually it's a new supplement, or it's like a mixture made by like a certain influencer, and it's not evidence-based. So whereas everything I've looked at has been like systematically reviewed, meta-analysis, and looking at the brands again are really important, because again, even that has such a big impact on quality. So it's really hard. It's like a real minefield, and I was really grateful that I could sit there, and it did take me hours. It took me hours going through all the research, and I learned so much through my own journey that I would not have known about. Even though I'm a doctor, I've been a doctor for almost 10 years. In July I've graduated. I've been a doctor for 10 years, and I probably learned 80-90% of my knowledge through my own journey. So it's crazy, isn't it? But, that's what we're not being taught enough. I feel like at medical school during specialty training, there's all just not enough information out there.
Yeah, absolutely. And then you kind of think, when it's time to go and see your GP, you expect them to know everything about everything, and of course they don't. And then the frustration comes in, and then the kind of masking of symptoms. Oh, take this, take the paracetamol, take the pill, take X, Y, and Z, which just masks the problem, which then leads me on to kind of ask, well, what should people do if you can't afford private healthcare, or go and see someone privately? Because of course there is that option to really hone in a more kind of bespoke, personalized approach. Your GP can't really give you that. Maybe there are some GPs out there that might spend a bit more time, or may know a bit more information, like yourself, that could probably direct them in the right place. But what should kind of everyday people do?
So there are obviously good resources. So the Fertility Network UK, they have like lots of different like evidence-based resources. There are books that are like scientific led, so such as It Starts with the Egg. That was a really good book, and it focuses on egg quality. It's very, very comprehensive, and sometimes what I found when I was like going through all the books, that it can lead to a bit of overwhelm, because you're thinking, I have to do all of this, or like there's everything in the environment out to get me. And you're just like, well, what am I meant to do? Like, if I do it, is it an all or nothing approach? And I think what I would say to people is that just do even small changes. Small sustainable changes are far better than going, like crash diets. And there's a reason why those diets don't work. I think that, I guess it's like maybe in terms of looking for your own knowledge, like one book I really would recommend is Taking Charge of Your Fertility. So it gives you so much more knowledge about like your female health and how your periods work, why your hormones do the things they do. But it's just more of a kind of like starting point and understanding. I think obviously with the whole private healthcare situation, what I would say to people is, before they start IVF, is try and understand as much as you can for your body, because the thing is with IVF, no one holds your hand. No one. I think people that I've helped go through IVF, they feel like I've just been left to it. I have to, well, I've been helping them. So like, I've been able to ask them, get them to explore the questions with a consultant. And obviously, clearly my whole remit of what I'm going to be doing is about giving everyone all the tools that they need so that they can then feel like empowered. And, I will obviously be going all into like the supplements, the specific diets for specific conditions, so you have things like anti-inflammatory diets, and then you have like Mediterranean, and then there's a lot of like different things, like there's like keto, and it's like, well, what is good for what, and what is, in terms of exercise, what is good for what, and all the other things that when you're like trying to, with your fertility, it's like, if you have the more information you have, and it doesn't necessarily have to be you don't have to spend thousands to get the information. Some of the information you can just collate from your own body through using a thermometer to track your temperature to see when you're ovulating, and honing in on specific ovulation kits, because not all the ovulation kits are equal. And say you've got PCOS, actually the ovulation kits can lead to false surges, so false positives. So you might later than you think you are, but you're checking the stick and you're like, oh, it's positive, but it's a false positive. So it's just like even small things like that so someone that I spoke to that had helped, when we just, that thing, she was like, oh, I realized I was ovulating 3 days later than the stick said, and the first time that she actually tried when she was ovulating, she got pregnant. So
wow.
It's just things like that, having more awareness of your body. So yeah, I mean, obviously, like, that's something that I'm working on. But there's other resources like Fertility Network UK and Taking Charge of Fertility, and it starts with they're the kind of main three resources that they look at.
Yeah. So what kind of things cause infertility then on a woman?
So the main cause of infertility, so for most common, is ovulatory dysfunction, so PCOS. But that's about 25 to 30% of like all women's causes. But there are other things like endometriosis. And again, for that, is if you have a known diagnosis of endometriosis, incredibly painful periods, then yes, you can understand. But for a lot of cases, there's silent endometriosis, and that's actually coming under the term of unexplained infertility, because there isn't an easy way to check for endometriosis apart from a laparoscopy. Sometimes MRIs. So the new gold standard that the international research shows that actually MRIs are an incredibly useful tool to check for endometriosis. But the problem is that nationally that's just not happening. No. So there needs to be updated services and guidances so people can get the right testing. And then there's like, adenomyosis, there's fibroids, there is, polyps, there can be like tube issues. So say you had like an STI years ago that was no symptoms, and then actually you developed, it kind of spread to your tube. So that's something called pelvic inflammatory disease. You can sometimes have tubal blockages. So obviously the egg physically can't get down. So there are a multitude of issues. Then there's more up and coming, more research coming out about like vaginal microbiome and like male microbiome. And a lot of that is kind of being one of the leading causes of recurrent implantation failure. So there are a huge multitude of causes. And sometimes they're concurrent. So you can have PCOS and endometriosis, or fibroids and endometriosis. So it's not, unfortunately, there's no like easy way to figure out exactly what the pinpoint issue is.
Yeah. And aside from kind of medical issues, what about age? Because a lot of people think, once you reach a certain age, that's it. You're no longer fertile and you can't have kids. What are your thoughts on that?
So, traditionally everyone's been like, oh, well, after 30, your fertility goes off a cliff. And actually, that's not the case. The research does show that after around 35, then it does start to decline, but not like, by 10% or 20% or something. It's not like, you suddenly go from conceiving, your chance of conceiving is like 80 to 20. It just does kind of start to slowly, gradually decline, between 35 to 40. But what I would say is that everyone is individual. So, that's where genetics play a part. Your family, that's where your diet, environment, lifestyle play a part. Like, there are so many different things. Say if you're like smoking and you're drinking a lot, and your mum went through menopause at 40, then realistically, the likelihood is that your fertility isn't going to be as good as someone that, whose mum went through the menopause at 50 and had a child at, 46, and that person exercises, eats well, has a good lifestyle. So there isn't a binary number. I wouldn't say to people that, oh, right, this is exactly when you're going to be infertile. It's just about, managing expectations and saying, yes, realistically, probably after 35 does start to decline a bit. But it's not, off the cliff edge.
Yeah, I read something the other day. I have no idea where I read it from, but it was almost about the rise of women having children in their 40s.
Yeah, well,
I mean, that just says it all. Then it kind of contradicts what your fertility goes off a cliff from 30 onwards, and you feel like there's kind of a narrative there that's kind of encouraging women to just have kids at 30 or in your early 30s or before or something like that, whereas women can have kids in their 40s, and it's an individual choice, of course. It's complete, everything is an individual personal choice, and your body is obviously very individual and very different from everyone, so you can't compare anything, really. You just can't.
No, definitely not. No, I completely agree. And I think that's the thing. Even I think it's very easy to compare when you're going through that infertility journey. It's like, oh, well, they managed to get pregnant just like that, and like, so why am I struggling? And then you start thinking, well, they did this, so I should do the same thing. And it's like, no, but everybody is unique. So it definitely, looking at your own individual circumstances plays a huge part. And I think for people that are, starting a family later on in life, I mean, I think, on the whole, the nice guidance says that if you're 36 and over, then if you've been trying for 6 months, then, you should go and get tests done. Whereas, like, say you were 30, they would say you should leave it a year. That's like the kind of national guidance. The guidance between different areas then slightly differs as well. But on the whole, that's because they're kind of saying like, oh, right, like, 36 and onwards, like, it just means you don't have as much time to play around with, because the kind of the fertility, it does start to decrease at a quicker rate, but not, again, it's individual.
So let's talk a bit about the IVF then, which is the kind of solution for women or men, I'm assuming men as well, if they're having fertility issues. Can you talk about that, and is it accessible for every woman or man? How does it work?
I think the one thing I would say about IVF is that there are no guarantees. And I think that, so I had a lot of people, I've been very open about my IVF journey. And, I see people kind of like, they talk to me and they say, oh, well, I might just go through IVF. And I'm like, it's not just going through IVF. It's incredibly emotionally and physically exhausting. And it's not to put them off. It's just more that people don't necessarily realize how intense it is. And, when I've been, again, like, helping some people go through the same process, and one of them said, she was like, I just didn't realize, like, how hard it was. The kind of the navigating the scans and the ups and downs of, there's no like fixed process. So, you'll have your period, you'll go in for a scan, and then you'll be given these injections. Those injections are obviously high dose hormones, so you have all those side effects. And then it's about, you're having to go in for tracking, and then sometimes it's like, oh, well, they're not growing as much, and then, or they're growing too quickly, and you're having to go in and out of work, and like managing all of that. And then it's like, then they're collected. It's like, well, how many were collected? And then, if they then combine them, it's like, well, how many grow? And it's quite, you're constantly feeling like, when's the next bit? And if it doesn't go to plan, which often for a lot of people it doesn't, people need more than one IVF cycle. I mean, that is basically the truth. If someone's had a single IVF cycle and they've managed to get pregnant, then that on the whole is very, very lucky. Like, it's, you've beaten the statistics. So in terms of accessibility, this is kind of where the postcode lottery comes in. On the NHS, again, the National Institute of Clinical Excellence, so NICE, did set out like fairly robust guidance about who should be eligible for IVF. And they say that most women should be getting, in theory, 3 cycles, as long as, they don't have other children. And the issue is here that, say you're with someone and that person has got children from another, previous marriage, or, then you're not eligible, even though for children. And then, so even within each area, even though it's meant to be 3, a lot of places don't offer 3 cycles. So in Birmingham, Solihull, where I am, they offered 1. Some areas will offer 3, but even if the offering, it's like, it depends on your weight, depends on your smoking status, depends on if you've had private IVF before. So for a lot of places, if you've had any private IVF cycles, even if those cycles haven't been successful, you're already considered ineligible. And then also waiting times as well vary massively. So sometimes you're waiting up to 2 years, which if you're 38, you'll really have that time to wait, unfortunately. So, and again, like in terms of eligibility, some of them will have a cut-off based on your blood tests. Some of them will cut off at the age of 37, 36. Some places will say 42. So it completely varies area to area.
Why is it so variable? Is it based on demographics, or is it just, people just, and who makes up these rules of eligibility by area? Who does that?
Someone in a board who's very high up that has decided. So normally there's like committee boards. So like ICC.
Is it to do with the hospital? Like,
part of it's hospital, part of it is also primary care. It's that funding that you get for the area, and they will kind of make up their own rules based on their research. It's sometimes meant to be linked to demographics. I don't necessarily see how it's linked to that. It's just, I guess, their justifications for what they feel is acceptable. So despite there being what the national, NICE says, there's still just so much variation. And unfortunately, there isn't anything that anyone can do about that or challenge that.
Yeah, see, that I find that quite kind of more difficult. I mean, so then it kind of, you want to live in the area that gives you the highest chance of being able to have IVF. So in terms of lottery, are there areas that just flat, like they don't offer it? We don't offer IVF in our area, or is it a case of?
Yeah, everyone does offer, as far as I'm aware. There isn't any area that says no, but as for the kind of length of waiting times and accessibility, that does vary massively. So it's not very straightforward. And again, like, they're constantly changing their guidance. So often when you go on the internet and you'll say, like, so you look in for your kind of region. So say I'd be like Solihull, I type in like Solihull IVF, funding criteria on NHS. So like, say you're like whatever area you're in, say that, you'll have guidelines from 2021. And then actually you'll have found that they would have changed since then. And even as GPs, you feel like you're constantly having to, the fertility forms are constantly changing. So yeah, it's not that straightforward. But what I would say to someone is that if they are kind of wondering what their accessibility is, and just kind of like typing in like, you know, IVF, NHS funding criteria, eligibility, and then their district, their area.
Yeah, there needs to be, like, is there a website that you can go into?
Fertility Network UK does offer a website, some information on that.
Okay. So the other thing I want to discuss is miscarriage. Now, you know, we talked about this briefly, and no one really talks about the male sperm contributing to miscarriage. I never knew that. I always thought it was a woman's problem, a woman's issue. And until you said that to me, I thought, wow, I don't know how many women actually know that, to be honest. Maybe there are lots of women and it's just me that never knew that. But can you talk a bit about that? Because as far as I know, that's not even out there.
No, it absolutely is. Like the male, you know, the male and, you know, the sperm and the egg, it's like 50%, 50-50. They come together. But if the sperm is of poor quality, you know, or there's fragmentation issues in there, then they also are responsible for that embryo, that fetal development. So if there's issues there, the fetus can't grow. So especially with DNA fragmentation, and that's not tested for in the NHS routinely. Sometimes when you get further down the fertility investigations, once you're under secondary care, often once you've had more, like several miscarriages, only then is it tested. And you just think, yes, it can be several £100s in terms of expense, but if that's the issue, it should be checked for beforehand. So yes, male count, it has a huge that's a big cause as to why, you know, unexplained implantation failure, unexplained infertility, or miscarriage can happen.
So how do you even know that? I mean, you said that men, like, they don't know, obviously, and there's no test. So how do you even go down that road? Like, what do you do?
Well, so this is the thing. Part of it is like, how much information do you want to get at the outset? There are, you know, you can test for fragmentation privately, so you can get that done privately. Again, part of it is like diagnosis of exclusion almost. So it's easier to tell when you're going through IVF cycles as to kind of like the root cause, especially when they've got like unexplained infertility. Because what happens at the IVF is that, you know, the eggs are extracted, the sperm, you know, that's collected. It goes for standard IVF. It goes into the petri dish. The embryos are formed. Then there's like a growth period. So normally they want embryos to grow to day 5 before they're then transferred back into the womb. And what they find is that for the initial period, the egg's responsible for that growth. Then after about day 3, the sperm takes over. If there's a huge attrition rate between day 3 and 5, that tends to point more to there being sperm quality issues. So obviously that's not a very easy way to tell, but, you know, if you've not had your fragmentation tested, you know, that and you're going through IVF, that kind of is a bit more of a telltale marker that there is something going on with the sperm quality, even if all the parameters might be okay.
Yeah, that's unfortunate. I feel like, you know, this is where women always feel like it's their issue, it's their problem, and it's because of them. And, you know, and then it feeds into the kind of mental health issues. If you're constantly having miscarriages, you know, it's quite, you know, it's a big, it's, you know, it's a very big upsetting period in, you know, in a woman's life. So I want to ask you about your kind of experiences with the taboo side of things with fertility. I know, you know, coming from South Asian community, and I'm sure there are other communities out there that also have similar things going on. You know, I'm South Asian. It's almost like, you know, go to uni, whatever, get married. Right, next thing, when you're having kids, yeah.
Yeah.
And that's always a question, always asked. Now, how do you navigate that? And what were your experiences with that? Can you just tell someone to, quite frankly, you know, bugger off? It's none of your bloody business.
I know it's so hard, isn't it? Like, I think especially in the South Asian community, the questions just I don't feel like people have a filter. And it's almost like you can't, if you say that to them, that's considered disrespectful, but almost the question that they ask, that's considered normal.
Yeah.
So, to be honest, I was quite lucky in that it wasn't luck. So when I was going through my issues, most of it was during COVID. So actually there wasn't that social interaction. There wasn't, I could almost hide away.
Yeah.
So actually I was for very, very that, I was like slightly grateful for COVID because of that. But for people that are having to go into the, social events and be constantly asked or say, oh, you're next, or, those kind of, it can be very, very difficult. What I would say to people is that, especially if you're struggling mentally, I don't think there's anything unreasonable in just not being able to be present for events. Like, the people will forgive you, if they're truly your friends or family, they will, once obviously hopefully things work out and you're a better headspace, like, they should understand. If they don't understand, then that's probably not someone that you wanted in your life anyway.
Yeah.
And I think what I would say to people that are kind of going through that is that this is the one time, like, you are allowed to be selfish. Like, you have to protect yourself because it's such a draining, emotionally exhausting experience. So, you can put yourself first. That doesn't make you a bad person. That doesn't make you a selfish person. You're just going through a lot.
Yeah. Can you talk a bit about Neco Health? So
Yeah.
I looked at that and I thought, wow, this is bloody amazing.
Yeah, so it's so the owners of Spotify, they are the ones that created this company, and they wanted to shift their focus into preventative and lifestyle health. So the whole remit of it is that, like, the whole consultation is about an hour, like the whole process. You go in, you have like a mole map scan done to check for any kind of lesions. You have like bloods taken. You have like your kind of like blood pressure, heart checked. So it's like a kind of thorough, like, it's like a overall investigation to see what your status is at, to pick up on anything that perhaps might be causing an underlying problem. Not, maybe you won't have any symptoms for it for a long time. It'll just be, it could be something that develops into problems. So say pre-diabetes or cholesterol or liver issues or, any heart checks. And the whole purpose of it is then, so you have that's like half an hour that you have with the nurse to check the bloods for the scan. Then you have a half an hour with the GP, which is where I come in. And we go through all the results because you get the results there and then instantaneously.
God, that's amazing in itself.
Yeah, exactly. So the whole point is that it's all there. You feel like everything's been addressed, that you've had that time to explore your concerns, to explore, what can you do to improve your specific lifestyle, your specific diet, because I think generally when you go see a GP, it's like, do exercise and eat healthy and that's it. Whereas, like, actually in reality, we know that people have busy work schedules. We know that people, like, sleeping patterns are unique. We know that people's diets are different, and like, it's just about taking it a step back and then spending that time really going through with someone what is actually specifically going to be beneficial in your instance, and then anything that kind of is like picked up or flags, then can be like investigated appropriately. So they do have like a team of secondary care specialists as well. So and I think people tend to actually, there's a huge backlog of scans, and they are trying to open up other clinics. But people really are interested because they want that time, they want that check, they want more understanding. So it's really popular.
Yeah, and all in one place, they're not
Yeah.
going from, the worst thing is I find, when you're going from one place to another, or being, go and see this specialist. Oh no, it's not that. Now go and see this specialist. And that takes time.
Yeah.
By the time you go around the houses and get all the test results and everything, it's and sometimes it's still inconclusive. you know yeah, so I think that's absolutely brilliant. So what would your kind of advice be to women that perhaps are going through infertility or don't even know that they are infertile? Now let's disregard the private route for now, because not everyone has that accessible to them. In terms of the first point of contact is definitely, it's going to have to be your GP, right?
Yeah.
Now, that, like we said, that's a 10-minute appointment. You're not going to address everything. So what would be your advice? Where do people go to get the information, or to just find out a bit more and then be equipped with the right information, and maybe push back and say, no, look, I think this and I feel this and I want to be referred, or can you even do that?
It is very difficult, unfortunately. I think the problem is that every area has got their own fertility criteria.
Hmm.
I would say that, doctors, again, there was like a varying, like there was different, I guess, I don't know how the best way to put it is, some doctors feel a lot more comfortable in addressing the fertility concerns and being a lot more proactive. Whereas other GPs are very much like, well, the guidance says it has to be a year, and before that, we're not doing any investigations. I think the one thing I would say to people, that I think a lot of people don't necessarily realise, is the whole BMI thing. In some areas, it's BMI of 30. Most areas, BMI of 30. Some areas, BMI of 35. If you are over those in terms of your BMI, the fertility clinic will reject your referral. So if there's two things I would say to do, one is like the weight, and then smoking, because they will automatically reject it. So again, it's incredibly hard for women. Say you've got PCOS and you can't lose weight easily. You're kind of in a bit of a catch-22 situation, because actually your BMI might be that way because it's out of control, but things like the Mediterranean diet, and things like minoxidil, again, because that improves insulin resistance, that can help with the weight loss as a side product. So I think being aware of your rights, I mean, again, like, because there is the NICE guidance, but that is very generic. It's not specific.
Yeah.
So again, the Fertility Network has certain information about where to start, but I think one thing I would say to people is just understanding your cycle is like my number one tip, because the sooner you understand yourself, the more power you've got, like, about, is something abnormal. Say you're ovulating on day 27, or say you have got irregular periods. So if you have got irregular periods, you are actually able to go and speak to a GP sooner and say, look, I've got irregular periods. I don't have to wait until the year mark.
Right.
I can investigate that sooner. And again, say you're over, like you're 36 and over. Again, you can say, look, I am eligible for like various blood tests. So those would be like my biggest kind of tips about that, as to where to start.
So I guess in terms of the GP, it's yeah, if you go in equipped with certain information, it's very useful. Now the BMI thing, I want to kind of talk a bit about demystifying that, because I've heard that the whole BMI thing is a bit of a, it's not really a great indicator of much.
Yeah, I agree, 100% agree. Like the again, like what the research is showing is that certain people, like, because of the genetics, because of, like, again, ethnicity, there's a lot of different factors that make your BMI, your basal metabolic rate, like, it makes it unique to you. But again, it's just this binary cutoff that someone has come up with but it just makes it easier for them to say yes or no rather than actually looking at the person as a whole. But we don't have any say over that, unfortunately. You know, I have referred people to the fertility clinic and said, look, I know they're over this BMI, but like they're trying everything they can do. And like, I know people that have had like BMI of 35, like that have conceived and not had any issues. But yeah, it's very regimental, like yes, no, no.
Yeah.
And it's frustrating.
But what about, you know, the guidance is about having a high BMI. What about if you've got a low BMI?
So they do, it isn't, you're meant to have a BMI of health, like, so over, is it like 19? So yes, they will reject it.
Oh, right.
And that as well. So yeah.
Yeah. Okay. So it's
two ways,
either end. Yeah. 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 I've got a bit of a problem with this whole BMI thing. I think I just feel like it's just definitely not an indicator of anything. I mean, I'm like, me as an example, I've always had quite a low BMI because I'm small, you know, my genetics, my whole you know, a small family, my kids have got a low BMI. And I don't know whether all schools do this, but in my kids' school, when they were in their science lesson, they made every child see what their BMI was. Yeah. I mean, I just thought that is that should not be happening. And some kids had a really high BMI, and then it said that they were obese. Some were really low, and they were like, "Oh, do I need to eat more? Why is mine really low?" I mean, why?
I just, yeah, it's a number, like, you know, again, I think that actually the one thing that they found better is like, you know, the waist, hip circumference, because it's more about where you're storing like any residual fat, or, you know, because again, like with the, like, you know, when they talk about the apple shape and the pear shape, and actually the apple shape, that's more to do with the insulin resistance, and that's linked to diabetes, and that's often common with, you know, their South Asian heritage. But, you know, some people just have the genetics, and there is a lot of research going on that some people do have that, and it's not like, it is again, it's like biopsychosocial. Like, I think part of it is looking at everything and not just like putting it down to one number.
Yeah, absolutely. I think so. Look, all your details are going to be in the show notes. So if anyone wants to get in touch with you, it's all going to be there. And of course, I'm going to put the details of Neko as well, if anyone wants to have a look at that. But Divpreet, thank you so much for your time today. It's been a pleasure to have you on.
Thank you for having me on. It's been great to chat.